Thank you all for being here. It's really an honor and pleasure to spend this evening with you. So we are going to really be talking about what can we do once local therapies such as surgery, radiation that you have heard today, when that has not fully cured your disease, what happens? Much as our focus is to try to get rid of the cancer, there are a group of patients today for whom radical prostatectomy or radiation hasn't really done the job. That's the focus that we are going to be talking today about some of the systemic options. So my outline is I'm going to sort of just define different clinical states in prostate cancer. I want to spend a little bit of time talking about hormone-sensitive prostate cancer, and also when androgen deprivation therapy becomes ineffective, that's called castrate-resistant disease. But I really want to spend a big part of my talk talking about the promise and clinical trials and what's ahead and what's in the future for this disease. So here's the clinical states. So we have clinically localized disease, which is what you have heard much this morning. And then if radiation or prostatectomy is ineffective, the first thing that really happens is biochemical recurrence, or you have a blood test that shows that the PSA is going up. What does that really mean? I mean, ultimately it means that PSA is a marker of activity of your disease. And if the PSA continues to go up, eventually you will see metastasis. And metastasis can go to lymph nodes, it can go to bones, it can go to other organs such as lung and liver. So you can either be in this top box where it's called non-metastatic castrate sensitive. The definition of that is that the testosterone levels are normal. That's what castrate sensitive is. And by our traditional imaging, there is no evidence of metastasis. So after a PSA recurrence, people could either be in that top bucket, or eventually, as PSA goes up and as our imaging improves, we can find metastasis from where this PSA is coming from. That's the bucket that I've outlined in blue. That's the metastatic castrate-sensitive one. For both of these groups today, the treatment really is androgen deprivation therapy. So what that means is these are medicines that are aimed at lowering testosterone. And testosterone is what feeds these tumor cells. So decreasing your testosterone sort of puts these cancer cells into a state of arrest. We are not getting rid of them, but they are sort of just in a state of arrest. And eventually, these tumor cells become so smart, they learn to grow even with this low level of testosterone. When that happens, that's the state in blue, which is metastatic castrate resistant. So one of the things that you heard about this morning is our improvement in our imaging technology. So previously, our scans that we had was the bone scan and CT scan. And as Dr. Aigaru said, it took a very high level of PSA before we could detect metastasis. But now with the PSMA scan, our ability to detect metastasis is pretty good, that even at a PSA of 0.5, we have the ability to pick up these metastases. So here's a picture of a patient who had this PSMA scan, and you can see that small red arrow pointing towards something in the rib. And these are now, you can target them with the SBRT that Dr. Bagshaw eloquently spoke about. So that's the whole scenario of oligometastatic disease, where you have just one or two sites of metastasis. So we have to ask, what is our goal in therapy there? Can we cure patients? It's hard to know because the way we understand how metastasis gets to bone is via the blood. So blood circulates, and it then finds a place, such as the rib, to go and grow there. So it's hard to know, once you develop one site of metastasis, are we just hitting that one and then you have blood circulating? So it's a little hard to know today whether we are able to achieve a cure by targeting these sites of metastasis. But even if we don't cure patients, I think there are other goals that are really important. Could we delay start of systemic therapy? All treatments have side effects. So by doing that SBRT, if we can delay hormonal therapy, that's a good thing. If we can improve time to metastasis, rather than have 10 different sites of bone disease, radiating this and delaying it would be a good thing to go after. And ultimately, I think much of what I'm going to be talking today is improving longevity. What do we have today with us that allows cancer patients to live longer based on the treatments that we have? So I want to spend a little bit, because many of you around have heard about Lupron, have heard about drugs like abiraterone, enzalutamide. These are all in the class of hormonal drugs. I just want to take a minute to sort of explain how this works. For prostate cancer, it's all about testosterone. Testosterone feeds these tumor cells. So every medical therapy that we have is aimed either at lowering the testosterone or making testosterone unavailable to the tumor cells. So this is a little complex chart just showing you your pituitary, your hypothalamus. These are all organs up in our head. All of those control how testosterone is made and how testosterone is delivered. But ultimately, the tumor cells have these receptors on the top called androgen receptors, and that's where all of these drugs work. So we have many. You'll hear about the easiest way to get testosterone level down would be by removing the testicles. So that's a surgical orchiectomy. Fortunately, we have now medications that do the same without having to undergo the surgery. So drugs such as leuprolide, goserelin. We have other drugs like Firmagon, Relugolix. So these are all some very familiar names. They all do very similar things by lowering testosterone. So I'm going to focus the next few minutes talking about metastatic castrate-sensitive prostate cancer, this bucket. And I just wanted to say that not every patient is the same. So within this bucket of metastatic prostate cancer, there's so much heterogeneity. So there is a patient who could have had radical prostatectomy and 5 years later develops metastatic disease. That patient is very, very different from a patient who just presents for the first time with a PSA of 500 and is found to have disease across multiple bones. The behavior, the biology, their life expectancy is different between these two groups. So clearly we can't treat everybody the same way, and we pick treatments based on their presentation, based on the individual medical issues that they have. But overall, what we know today, 10 years back, if somebody presents with metastatic disease, our treatment was so simple, we would do just Lupron, and that would be it. So much changed in 2014. For the first time, instead of just giving Lupron by itself, there were multiple trials that showed us that by giving Lupron plus chemotherapy, we were able to make people live longer. So in 2014, our standard changed. So for somebody who comes in with metastatic disease, we no longer give Lupron alone. We started doing Lupron plus chemotherapy. Now, clearly, chemotherapy has its own side effects, and if we can avoid chemotherapy, are there alternates to chemotherapy that we could do? Fortunately, there were multiple of these hormonal drugs, such as abiraterone, such as enzalutamide. All of these drugs were approved for patients with pretty refractory disease who had all therapy. So all the investigators did was to take those drugs to the earlier stage of disease. So rather than giving Lupron plus chemotherapy, there were multiple trials that looked at combining Lupron plus abiraterone, Lupron plus enzalutamide, Lupron plus apalutamide. So these are just some curves. You've seen multiple of these curves all day today. These are just the curves on the top is superior compared to the curve in the bottom. And that difference is what the drug has done, the experimental drug. So for instance, if you take the first one called GTUG study, the group who got Lupron plus, this is still in chemotherapy, resulted in an improvement in outcomes. So all of these trials showed us that adding the chemotherapy to Lupron improved outcomes. And again, similar to chemotherapy, we have now also shown that Lupron plus one of these hormonal drugs have an improved outcome compared to Lupron alone. So today in 2022, the current standard of care, if somebody has metastatic disease, would be to have Lupron plus one of these drugs. Whether you choose chemotherapy, whether you choose one of these drugs, there's a lot of factors, right? One is oral, one is IV. Some people may be living very far away and they wouldn't want to come to the center to get IV. But the bottom line is we have choices that we didn't have 10 years ago. And then there have been trials, should I pick chemotherapy or should I pick one of these hormonal drugs? You can see how similar these two curves are, and they are just telling us that it doesn't matter whether you do Lupron plus chemotherapy or whether you do Lupron plus hormonal drugs, your benefit is about the same. In fact, now the field has moved to triplets. So we think at least in 2022, all patients should be getting at least 2 drugs. When we go back and look at real life data and look at across the United States, only 30% of patients are really getting these doublets. So we still have a lot of work to do in improving education, improving communication across patients and providers. But the field is sort of moving into, should we be doing triplets? Should we be doing Lupron, chemotherapy plus hormonal drug? Would that be better than just Lupron plus chemotherapy? So there may be certain groups of patients for whom the triplet would be important. But again, it's incredible that we have all of these choices for patients now. So this is just a list of all of the trials that I just mentioned. I want to move on to the castrate-resistant space. Unfortunately, all patients who get hormonal therapy for metastatic disease, at some point, these tumor cells become sensitized to the effects of hormones, and they become resistant, meaning that despite being on Lupron, you see the PSA go up, or there is disease progression. For that group of patients today, we have a lot of drugs again. Within the hormonal axis, there are drugs such as enzalutamide, abiraterone, apalutamide, and darolutamide. There are chemotherapy drugs such as docetaxel and cabazitaxel. We heard this morning about one of the drugs, the lutetium 177, which is a DNA damage drug. We also have some unique drugs that are called PARP inhibitors. If we were to do some genomic testing and you have a unique mutation, we now have drugs that can be given specifically for that in the class of precision medicine. I want to focus a little bit on immunotherapy. Immunotherapy today, we all have an immune system, and we know that in almost 26 cancers today, immunotherapy is approved and can result in some cures for some cancers, including melanoma, kidney cancer. In prostate cancer, it's been an incredible challenge because for some reason, the prostate cancer is considered a cold tumor and hard to stimulate the immune system. So I'm going to come back to that when we talk about some of the clinical trials that we have. So how do physicians pick one drug or the other? There is a network called National Comprehensive Cancer Network. Many of the academic programs are part of that, and they put forth guidelines for providers so that providers can take a look and say, for this given patient, if he's had this drug, what would be the next drug to give? So this is just a flavor. I'm not expecting you all to be able to read every one of those. Finally, I want to touch upon the trial that's really, I think, has a lot of promise, which Dr. Igaru spoke this morning. This is called the VISION trial. It's a randomized study where, as you know, the tumor cell has this protein expressed on its surface called PSMA, and we now have an antibody against this PSMA. So Dr. Igaru spoke this morning about our imaging with the PSMA PYL scan, but we now have the ability to link the antibody at one end to this radiation source called lutetium-177. So this was a trial. We had this trial here at Stanford. Patients were randomized, so one half got this lutetium-177 and the other half just got supportive care. And you saw the results this morning that this resulted in improvement in longevity, which is our gold standard. Getting PSA down is good, but ultimately people living longer is really what we want our drugs to do. So this drug did result in prolongation of life. And this waterfall plot that you see down here just tells you what fraction had their PSA drop. So I think it's about, let's see, even with my glasses, I can't read that. So it's 46% of patients on the lutetium had a drop in their PSA compared to 33%. And the top shows you, for those patients who had lymph node disease or who had liver metastasis, what was the likelihood of tumor shrinkage? So this drug resulted in a PSA drop, it resulted in shrinkage of the tumor, and most important, it resulted in prolongation of life. So as was said this morning, this drug is now FDA approved, and we have it for patients. Where the FDA approval is for patients who have had hormonal therapy, who have had chemotherapy. That's where this drug called Pluvicto is currently approved. And unfortunately, we have to sort of stick to that because that's what the FDA label is, and that's what insurance companies are going to allow to pay for your care. But could there be promise in moving something like this forward? And I'm going to talk about that in my next slide. So I'd like to summarize this part of my talk by saying that recurrent disease, once it happens, it's more like a chronic illness. You have high blood pressure, you're taking high blood pressure medications. Cancer becomes like that. You're going to have times when you're on some drug for a period of time, and when that becomes ineffective, we have to move on to other treatments. Androgen deprivation therapy is the mainstay. You know, the Lupron, once we start, for most people, it's for their lifetime. We know that chemotherapy and hormonal drugs work, and we are really looking forward to a new class of drugs so that there could be more that can be offered to patients to improve their life expectancy. So I think in the last 5 minutes, I'm going to quickly touch upon some of the clinical trials and where we have some promise. So this is the castrate-resistant clinical state that I said. You know, patients go from first line to second line to third line therapy. This trial, called the SPLASH trial, is looking at this exact lutetium-177. So it's not the same compound, but instead of using it in people who have had hormonal therapy, who have had chemotherapy, this trial is being given to patients in a much earlier part of their illness. So after the first hormonal therapy becomes ineffective, this trial is being run here at Stanford. It's being done by one of our colleagues in nuclear medicine. Again, these trials are randomized because that's the only way we can know with certainty whether the drug is doing something. So patients get randomized either to this lutetium-177 or to another hormonal drug. The beauty about this is for those patients who get on the hormonal drug, when that becomes ineffective, they are automatically crossed over to get this lutetium drug. So this is a trial called SPLASH. We have it open at Stanford, and it's actively enrolling patients. I spoke a little bit about immunotherapy and drugs such as Keytruda, which many of you see on TV, on billboards. That's an immunotherapy drug, and it's really found pretty remarkable effect in many, many cancers, but not in prostate cancer. So what can we do to make immunotherapy more effective? We know that as a single drug, it's not effective. What if we combine it with other drugs? Will that make immunotherapy more effective? And that's exactly what this trial at Stanford called CONTACT-02, where we are looking at this drug called atezolizumab, which is very similar to Keytruda, but we are combining it with another oral drug called cabozantinib. All of these are just intent to try to make immunotherapy more effective in this disease. Similarly, there's another immunotherapy drug, just like we spoke about the PSMA, which you now have an antibody that you use in that lutetium. This is another trial trying to have two arms. They're called BITE therapies. One arm is targeting the PSMA, which is on the tumor cell. The other arm targets our own T cells, which are the immune fighting cells in our body. So by targeting both the tumor cell and stimulating your T cells, the hope is that this will make the cancer regress and allow your immune system to get stimulated. So again, we have this as a clinical trial for patients who have had multiple prior therapies, hoping that this will bring again a new treatment for our patients with more advanced disease. Finally, I want to stop with this. We know that hormonal drugs such as enzalutamide, abiraterone, those drugs are quite effective, but they develop resistance. And so there is a lot of interest and research in trying to find new drugs that target the androgen receptor. One such is this drug that's made by Celgene, where they try to degrade the androgen receptor. So if you just break down the androgen receptors, could that be a better way to treat the cancer? This is an oral drug, so we really have a lot of hope that drugs like this would be effective for people where abiraterone and enzalutamide have become ineffective. So I think I'm going to, this was a trial that Dr. Bagshaw spoke about in the morning, looking at high-risk radiation patients. We are using this genomic testing. So your own biopsy is being tested through this test called Decipher. And based on the Decipher number, we are going to decide if somebody should get more hormonal therapy or can we get by doing less. That's what this trial is, and Dr. Bagshaw is a PI on that one. One more immunotherapy drug. I think I'll just stop with this. I wanted to just say none of our research will happen without an incredible research team. So this is our medical oncology research team who really makes it all happen. And we really couldn't be conducting all the research that we do without their support. So I'll stop with that, and I'm happy to take any questions.
Thank you, Dr. Srinivas. We do have a few questions. If you can please write them down on cards, and we'll ask them from live stream as well. So the first question, what genetic test allows a prostate cancer patient to see if he has the genetic mutation that would benefit from a PARP inhibitor?
So there are multiple commercial vendors that are available. Essentially, they take your biopsy and they send it out for testing. There are different mutations that are looked at, but the one that for which PARP inhibitors really work are called BRCA, BRCA. It also happens in women with breast cancer. So these type of tests can be done off tissue. But not all patients with prostate cancer have available tissue. So we now have technology that allows us to detect these mutations off your blood. So again, those are called circulating tumor DNA. So these tests for BRCA mutations can be done either from the tissue or from the blood. And there are many vendors that do that.
Next question. Thank you. How long are the various treatments effective at treating prostate cancer, and does prostate cancer mutate at any point and thereby becoming unstoppable?
Yeah, there are each of these drugs with hormonal treatments. Unfortunately, it has a finite time for which it works. And we are in the process of understanding what is the difference. Why is it in some people it works only for 6 months, and for others they are able to go on it for more than 35 months? There are some differences, and I think we are just in the process of understanding what the difference between these two groups are. Prostate cancer does develop mutation. There are mechanisms of escape, which is why you need new drugs coming in. Hormonal therapy works for a period of time and then quits. That's why we come in with chemotherapy. We come in with drugs such as PARP inhibitors if you have the appropriate mutation, or treatments such as lutetium-177.
Thank you. What is or is there any role for radiation regarding metastatic therapy?
Yeah, 100%. It's extremely effective, but we want to use radiation at the right time for the right patient. So 3 indications in my mind for radiation are: if somebody has pain, it's extremely effective in eliminating pain with radiation. That's number 1. Even if somebody doesn't have pain, if you have a metastasis in a threatening site, such as your femur or up in your spine, rather than prevent, so we'd like to prevent a fracture, we like to prevent something bad, radiation is given in that instance. And the third one is that oligometastatic disease. If we can find just one site, giving radiation to try to delay additional hormonal therapy are all indications for radiation in patients with advanced disease.
Do any of these treatment options differ for men if they're in their late 70s versus 80s?
I mean, the older we get, the harder treatments can be, because no treatment comes without side effects. So really it comes down to how much does our body allow us to take these side effects. Hormonal treatments are a little bit easier compared to chemotherapy. That's why the search continues for more effective treatments like hormonal treatments, immunotherapy, compared to chemotherapy, which sort of just gets to your entire body. But as, again, older patients, I think our ability to deliver the treatments can be a little harder.
Does sexual intercourse increase testosterone, and should we be abstaining until the treatments are done?
Not really. I don't think that's really been shown, so I don't think there's any truth to that.
How does ADT impact the adrenal glands?
So testosterone has multiple sources. The most common is the testicle. 95% come from the testicle. But our adrenal glands that sit on top of the kidney also makes androgens. And these androgens get converted to testosterone. So drugs such as Lupron only affect the testosterone that comes from the testicles. So we rely on these other drugs such as abiraterone, enzalutamide, to help decrease the androgens that come from other sources.
And finally, our last question, what are the chances of cure at various prognosis points in these treatments?
Sorry, I didn't understand that question.
So what is the chance of cure with these type of treatments that you discussed?
Yeah, I think, that's the million-dollar question. We know with hormonal therapy, we are unable to cure prostate cancer that's metastatic. Our hope is with immunotherapy, because that's what's been shown in other cancers. Patients with melanoma who have widespread disease even to the brain, today about 10 to 15% of them are cured. The same is true for kidney cancer. We have patients with kidney cancer that's widespread, that's gone to their lungs, who are now without any therapy and who have been cured with immunotherapy. Really, my hope for the future is that we find drugs like that help us stimulate our own immune system to help fight this. We are not there yet, but I certainly hope that in the next 5 years, there is something that will change the natural history that allows us to offer that type of treatments to patients with prostate cancer.
Great, thank you so much, Dr. Srinivas. Oh, one more question.
Sorry. Doctor, lutetium-177 with the PSMA, using it here at Stanford since 22 June, 3 months ago. How effective have you found it so far? Does it agree with the spread down 60% and the dye down 38%?
I mean, it's still early. You know, I think we have treated close to about 35 patients to date, but they are all early in their course. You know, for some patients, it's really effective. It doesn't work 100% of the time, but certainly there are patients who have had up to 2 years without needing any additional therapy.
Okay, is it targeting only the prostate cancer cells and leaving the healthy cells around it alone?
Yes.
It is.
Not all, you know, so it does have an uptake in the salivary glands. So for some patients, mouth dryness is a common side effect that happens. It does affect your bone marrow. So for some patients, a little bit of anemia and fatigue is not uncommon either. So it's not perfect, but it's certainly better tolerated than chemotherapy.
Oh, yeah, you want to avoid chemo if you can. Second question. The spread med leuprolide and abiraterone with prednisone stopping cancer, an average of months 30, I've been told by my doctor. You mentioned 35 months ago, a minute ago. Would you go beyond an average of 30 months?
I mean, as you know, by statistics, we say that this is a median, which means there are people at both the ends of the spectrum. So that's the average, and that's what we saw based on clinical trials. Yeah, sure, there could be people at both ends.
In your experience, what do you say with the max would be?
We've seen people who have been on it for 4 years.
4 years.
Yeah.
That's the max you've seen?
Yeah.
Very good, thank you. Other question, next question is?
We're going to make this the last question just for the sake of time, and then we can take it offline.
Other treatments to stop the prostate cancer. You mentioned in the hallway that you know, besides lutetium now is the best one available. You know, other treatments that are in the pipeline or whatever to stop prostate cancer. Can you mention those? Talk a little shortly about those.
I mean, some, again, it's in the same class. We have immunotherapy drugs that are FDA approved, that we have available. There are chemotherapy drugs that are FDA approved. There are other hormonal drugs. So for somebody who's had abiraterone, the likelihood of other hormonal drugs working is a little less. But that's because there is a lot of resistance. But there's a lot of, there are at least about 4 currently FDA-approved drugs that you can go see your doctor and they can give it to you.
Okay, one last question. If you're not resisting from the beginning, from time 0, does that last forever?
No.